Hello students, good afternoon and welcome to Dermatology.
Hello students, good afternoon and
Welcome to Dermatology Last Resort Revision Session. So as you know, we are doing all these subjects in these 18-19 days, and the aim of these sessions is to familiarize you with important topics or questions which are asked in the respective subjects. So please remember, this is last resort revision, or I would like to say it as a quick revision session. It's not the last resort. You still have time. You can brush up your knowledge. The whole idea of these sessions is to tell you what are the most commonly asked topics in the exam, so we can brush it up with you quickly, and so that even if you are a little hesitant about any subject, this will help you quickly hold grasp on that subject and quickly revise that subject. So I have prepared this session in the format that I will be first giving you an MCQ which you can quickly answer in the chat box, and then related to the MCQ, whatever questions are asked in that particular topic, that we will try to cover as early as possible, so that we can cover the maximum number of topics. So if you have any queries, please feel free to interact in the chat box. In fact, it becomes more convenient, more interesting if you guys are constantly interacting. So I will be a little quick because I want to cover the maximum topics. You will get the annotated PDF at the end, but in case there is something you would want me to explain, you can put it in the chat box. I'll try to do that by the end of the session. So let's get going. And okay, so someone requested it to be a English session, so I will try to do that, but are you all comfortable with that? Give me a thumbs up. अगर हम English में बात करें तो will you all be comfortable, because I know there are a lot of students who have a difficulty in Hindi. So if everyone is okay with that, I can do English, otherwise I'll continue with English. Okay, so this would be English only then. So as you know, PrepLadder has introduced English lectures. Both LRR and main course videos are in English. So those people who are more comfortable with English, please go to those videos, and it would be very, very convenient for you. So now starting now with the first question. A simple one, my most favorite topic in dermatology, and so I always start with this. A 30-year-old male presents with flaccid bullae on an erythematous base and erosions over the oral mucous membrane. Perfect. Very good. So I already have the answers. The blisters develop painful erosions and rupture. What would be the most likely finding on immunofluorescent examination? So there is a lot of information in this question. You have flaccid bullae. You have flaccid bullae, you have erosions over the oral mucous membranes, and now the question is not asking you the diagnosis but the immunofluorescent examination. Now whenever you have flaccid bullae with erosions on the oral mucous membrane, it is a clear-cut diagnosis of Pemphigus vulgaris. If I have these two things in the question, flaccid bullae, erosions on oral mucous membrane, I can with confidence say that this is a case of Pemphigus vulgaris. And when you have a patient of Pemphigus vulgaris, the most diagnostic test or the gold standard test is doing a direct immunofluorescence. So please students, I am trying to tell you all the important topics. So please answer, like gold standard test for Pemphigus vulgaris, it is direct immunofluorescence. And when you do a direct immunofluorescence in a patient of Pemphigus vulgaris or even Pemphigus foliaceus, what you get is a fishnet IgG deposition in the epidermis. I will just show you the image. Now, very good. You all told me that C is the answer. Now, you need to tell me what would be the condition, clinical condition, where you will see D as the DIF finding. In which clinical condition will you see granular deposits of IgA in dermal papilla? Quickly. So this was easy, that it is C. I am asking you for option D. What would be the clinical condition? Very good. Yes, it would be Dermatitis Herpetiformis for this. Then linear IgA deposition, option A, linear IgA deposition in dermoepidermal junction is seen with linear IgA disease or also called as LAD. Linear IgG deposition in dermoepidermal junction. So, a lot of you are, okay, so maybe you are telling me for other options. For option B, it is bullous pemphigoid. So, these are all important DIF findings. So, I will quickly go through this important topic. So, whenever you are given in the question any bulla or erosions and you are thinking of this pemphigus or pemphigoid group of disorders, these are the important pointers that you need to remember. So, either you would be given a patient of Pemphigus vulgaris in which you will have this oral erosions which are non-healing, you will have flaccid bullae which rupture to give you these erythematous erosions. As you all rightly said, on histopath examination, you get suprabasal split and a very important finding called as row of tombstone appearance. So, row of tombstone appearance and suprabasal split are two important histopathological findings. What is the target antigen here? The target antigen is desmoglein 3. Remember, both desmoglein 3 and desmoglein 1 are the target antigens, but if you have to answer one, it should be desmoglein 3. So, target antigen is desmoglein 3, and in DIF you see fish net pattern. So, all these are very important pointers towards Pemphigus vulgaris. Moving on to the next image quickly. So, you know I am dealing with which section of dermatology. What is this? You are seeing crusted erosions on seborrheic distribution. So, crusted erosions on seborrheic distribution. You hardly see any bulla. So, you hardly see any bulla. You do not see any oral erosion. So, there are no mucosal involvement. So, mucosal involvement is not there. You see crusted erosions. Yes, this is a patient of Pemphigus foliaceus. F for first. So, here my target antigen is desmoglein 1. Remember, F for first, F for first. So, desmoglein 1 is the target antigen. Since it is superficial, I get a subcorneal bulla here. Subcorneal bulla, and since it is very superficial, it sheds off, it ruptures easily, and so I hardly see any bulla. And since in oral mucosa it's predominantly desmoglein 3 and here the target antigen is desmoglein 1, I do not see mucosal involvement. Clear? So, these are very important findings. When I look at the biopsy and DIF, I already told you this is Pemphigus vulgaris. Sometimes they give you a histopath image. So, you can see this basal layer. So, this is a suprabasal split and you see row of tombstone appearance. So, this is a histopath image of Pemphigus vulgaris. If they had to give you foliaceous, you will see split somewhere around here, subcorneal. And this is the classical fish net pattern on DIF. Direct immunofluorescence shows fish net pattern. Clear? And DIF is the diagnostic test, not histopathology. Please remember this, right? Thank you so much. I forgot that. So, if you do a Zhang smear, you see acantholytic cells or Zhang cells. Acantholytic cells or Zhang cells on Zhang smear. So, these are all important findings, and so foliaceous and vulgaris needs to be differentiated. I have covered all these points, so I will not repeat so that we do not waste time over here. Then what is this? Here I have tens bullae. If I say tens bullae and I give you an age bracket of 40 to 60 years, if I give you tens bullae and age bracket of 40-60 years plus minus mucosal involvement, it may or may not be there. This is a patient of bullous pemphigoid. Now remember, when I was talking about vulgaris and foliaceous, those were intraepidermal immunobullous disorder. Here the split was in the epidermis. Now I am dealing with subepidermal immunobullous disorder below the epidermis. So my split will be at the dermoepidermal junction or basement membrane zone. The most common entity which is asked in this section is bullous pemphigoid. Here you get tens bulla because the bulla is subepidermal. So here the split is subepidermal or at the dermoepidermal junction. And so when you do a DIF, this is what you see. You see linear deposition of IgG and you can also see deposition of complement 3. So linear deposition of IgG and C3 on DIF. The split is subepidermal on histopathology. And another very important point about bullous pemphigoid, it may be preceded by urticarial lesions. So sometimes in the history they give you that there were urticarial lesions preceding these bullae. So if there is a precedence of urticarial lesion, that also points towards bullous pemphigoid. Clear? Now there are few important differentiating points and this would also cover the important things that I have not covered. So when you have to differentiate between pemphigus and pemphigoid, remember the mnemonic MINAR. MINAR. Mucosal involvement, intraepidermal bullae, Nikolsky sign, acanthocytes also called as Zank cell and row of tombstone appearance. So MINAR is positive in pemphigus group of disorder, it is absent in pemphigoid group. So in bullous pemphigoid you do not see a positive Nikolsky, you do not see Zank cells or acantholytic cells, you see a subepidermal split, you do not see intraepidermal bulla, and mucosal involvement is only present in 30% of the cases, right? And also pemphigoid can usually present at a later age group. Another important clinical finding is whether the bulla are flaccid or tense. Clear? So if you remember these two important tables, you would be easily able to crack any immunobullous disorders. So good, I am just seeing if yes, age is 60 to 80 years, preceded C3 we have done, and MINAR we have done, pemphigoid treatment, right, good. Now when we talk about treatment, it is mostly immunosuppressants and oral steroids. In pemphigoid group of disorder, Dapsone is the drug of choice. Now usually I have seen that if I have to ask you this class of dermatology, they will usually give you a clinical question and rarely give you on treatment, because for you it's the clinical diagnosis which is more important. Now just to complete the topic, in the same section sometimes you can get a history of a patient presenting with itchy excoriated papules which are mainly present on the extensor surfaces of the body. They are coming and going, they are not responding to normal topical applications or anti-allergics, and patient, you do a DIF and you see this, the D option which was there in my question, you see some deposits in the dermal papilla or immunofluorescence in the dermal papilla. Yes, you are all right. The answer here is Dermatitis Herpetiformis. What is the antigen in Dermatitis Herpetiformis? What's the target antigen in Dermatitis Herpetiformis? Quickly tell me. You all know that it is IgA, and I know this is associated with gluten sensitive enteropathy. So in the exam, in the question, they may also give you gluten sensitive enteropathy or some relation to that. Then another thing, that it's itchy excoriated papule, which I already told you, there are no bulla. There are no bulla here, and you see this papillary tip immunofluorescence, papillary tip immunofluorescence. Very good. So here the target antigen is transglutaminase. So though DH comes under subepidermal immunobullous disorder, it is a different entity, because here the target antigen is different and there is no bulla formation. What is the treatment? You have to stop gluten. You have to stop gluten, and so you have to avoid barley, rice, oats and wheat. You have to avoid barley, rice, oat and wheat, and you have to give Dapsone to the patient, right? So, dermatitis herpetiformis, D for D, avoid gluten, transglutaminase, gluten-sensitive enteropathy and papillary tip immunofluorescence. All these are important questions related to dermatitis herpetiformis. Absolutely right. Yes, you're right. You can give MR or maize and rice can be given. Yes, you can give quinoa also. Clear? So, this was about our important immuno-bullous disorders which are asked. Next important question in this heading comes about target antigen. So, you should know, or sometimes they can also give you various disorders and you have to put it in the order of their target antigen from top to bottom. So, remember I told you desmoglein 1 is Pemphigus foliaceus. So, that would be at top. Pemphigus vulgaris is desmoglein 3. BP antigen is BP 180 and 230, right? Beneath that, we have cicatricial and mucous membrane pemphigoid, and below that we have EBA or bullous SLE, which is collagen 7, right? So, there is a mnemonic to remember this. First we pray, then can eat. First foliaceus, vulgaris, bullous pemphigoid, and then can eat, C for cicatricial and E for EBA. First we pray, then can eat. So, it's an easy mnemonic you can quickly write in the exam, and these are the various antigen. BP 180 and 230 is easy to remember. Then you should know collagen 7 for EBA and bullous SLE, and we already discussed transglutaminase for dermatitis herpetiformis. Clear? Yes, you are right. You can eat pasta, but it should not be made of maida. So, that's very important. And if it is not mentioned in the question and you are given food items like pasta, rice, corn or something like that, then please assume that pasta is made of maida, which is a derivative of wheat. So, yes, that cannot be eaten. Okay, because this special kinds of pastas and all may not be given in the exam, and so if it's not mentioned, assume that the pasta is made up of wheat or maida, and so should be avoided. Whereas dosa is made of rice, so it's allowed. Clear? So, are you guys with me? Is this okay? Should we move on to the next topic? Anything in this topic which you are not clear? So, good question, Dr. Kanchu. I don't know why maize is not having gluten. Basically, this is how it is. Great. So, I'll move on to the next important topic, and here's the question for that. A patient presented with 10 to 20 bilateral but asymmetrical erythematous plaques as shown in the image. The lesions are of varied size, have bizarre shapes, irregular borders, geographic appearance. So, what is my diagnosis? Obviously, you all know, since I have given the spectrum, I am talking about leprosy. But what spectrum of leprosy am I talking about? B, mostly, or most of these students are going with B. Some are going with D, C, BB, BT, okay. Right. So, what is it? Okay, what is this image telling you, and what is this? Why is there so much of confusion here? Now, even if I don't look at this image, okay, because image can sometimes overlap between the different spectrums. Look at the question. The question is saying you 10 to 20 bilateral asymmetrical lesions which are of varied size, geographical appearance, bizarre shape, very irregular borders. This when they say geographic appearance, when they say bizarre shape, when they say bilateral but asymmetrical, now we are going towards the lower end of the spectrum. Okay, and in the lower end of the spectrum, if they say bizarre shape and geographical appearance, it has to be BB. BB is the most unstable phase, and it is characterized by geographic or bizarre shape lesions. So, when they are giving you any question on leprosy spectrum, please look into the specific descriptions that they are given. Even if you look at the image, it is an image of inverted saucer lesion. Now, inverted saucer lesion is most commonly seen in BL, but can be seen in BB. So, this is how the examiners confuse you, and that is what I tried to do here. So, then look at the question. So, this is a typical image of inverted saucer. So, if there was an option of BL, then I could have got confused, but that is why there is no option of BL here. Inverted saucer appearance is a feature of BL but can be seen in BB. And this bizarre shape and geographic is a feature of BB, which is the most unstable stage. Clear? Right? No, there is no pseudopodia here. I'll just show you what a pseudopodia is. So, let me quickly walk you through the lesion. So, before I come to this table, let's see this. What is this? This is hardly asked, but just to complete it, this is TT, the topmost pole. Very, very well defined lesion. You see loss of hair and everything, but they hardly give you TT, so I'll not spend much time here. What is this? Someone confused with pseudopodia. So, this is a pseudopodia. This is a satellite lesion. So, this is my BT Hansen. So, when I have TT, I will have less than 10 lesion, less than 10 centimeters. So, less than 10 in number, less than 10 centimeter in size, very well defined, no ill defined lesion. Total loss of sensation. So, this is all my TT. Now, when I talk about BT, now I have 10 to 20 lesions, which are 10 to 20 centimeter in size. But the most important thing is I see pseudopodia and satellite lesions. So, these are two features of BT Hansen. Please, if you understand, it becomes very easy. TT is very well defined. My immune system is very strong. BT, now the infection is trying to spread. So, I have a well defined lesion at most places, but at areas it is starting to become ill defined, and that is why I have pseudopodia. And now the infection is trying to spread, so I have satellite lesions, right? So, in BT you see pseudopodia and satellite lesions. Sorry, good, yeah. Okay, sorry Dr. Devaki, I understand. Yes. Next, this is inverted saucer, or what I showed in the image. Inverted saucer is a feature of BL Hansen. Now, as we are moving towards the lower pole, we have bilateral lesions, but they will be asymmetrical because they will become symmetrical only when we reach the LL pole. So, bilateral lesions which are asymmetrical, numerous numbers, you will have both small and large lesions, and you have inverted saucer appearance in BL Hansen. Whereas, this is the most unstable form of leprosy. The patient stays in this phase very, very briefly, and that is why it is called as BB Hansen or borderline. So, it is the most unstable form, and here you see map-like configurations or geographical lesions, because now what is happening is from tuberculoid pole, patient is going towards the lepromatous pole. So, now my body is confused, bacteria is confused, so it is going all over. So, I have map-like or geographical configurations that I see. So, whenever they say bizarre shape, geographical configurations, map-like configurations, please understand it would be BB Hansen. Clear? And then when I move to LL pole or the lowermost pole, I will have multiple bilaterally symmetrical small lesions. I will have glove and stocking anesthesia, which would start at BL Hansen, right? So, quickly I will go back to this table. So, now, this is TT, BT, BL and LL. So, I already told you, you have single lesions. This in tuberculoid pole, you have totally anesthetic lesion. This is all been covered. Satellite lesions. In BL, I have irregularly spaced lesions. Then here we have completely bilaterally symmetrical lesions. Glove and stocking anesthesia starts at BL also, but is more pronounced in the LL pole. Here in the tuberculoid pole, you have lesional anesthesia, right? AFB, if you do, it is negative here, but if you see in the lepromatous pole, you have 5+ to 6+, and even globi may be present, right? So, these are important features which will help you differentiate between different spectrums of leprosy, and you should be able to do that. Clear? Yes. So, punched out lesion, if they are specifically asking you about punched out lesion, it is more common in BB than BL. Inverted saucer lesion, more common in BL as compared to BB. Glove and stocking anesthesia seen in both BL and LL but more pronounced in LL Hansen. Clear? Any other questions which are related to this topic? I hope you're able to understand this, how to differentiate between different spectrums of leprosy. Right? Should I move on? Then students, I do not have a lot of time, so I cannot cover whole of leprosy, but what's important here, please look into the treatment and please look into the lepra type 1 and type 2 reaction. Very important question that comes in lepra type 1 and type 2 reaction is the treatment. Now, if they ask you treatment of either lepra type 1 reaction or type 2 reaction, please remember the treatment of choice is oral steroids, no confusion, for both type 1 and 2 reaction. Please don't confuse it with the treatment of leprosy. You all know treatment of leprosy is MBMDT. I am not covering that. You know there are 3 drugs, but what I am talking about is the treatment of type 1 and type 2 reaction. Both the reaction, my treatment of choice is oral steroids. Thalidomide is a second line treatment of choice in type 2 reaction. It is not the first choice drug. Clear? Yes, good. NSAIDs can be given in type 1, right? So, oral steroids are the drug of choice for type 1 and type 2 reaction. Quickly revising both the type of reaction. So, type 1 reaction is a type 4 hypersensitivity, whereas type 2 reaction is type 3 hypersensitivity reaction. Type 1 lesions you see in upper spectrum, type 2 reaction you see in lower spectrum. In type 1 you see that existing lesions increase, they become erythematous, edematous. In type 2 reaction you see new crops of lesions with fever. Dr. Jensi, yes, Malayalam. For that you have to teach me Malayalam and then I can try teaching in Malayalam. Type 4 hypersensitivity, yes, this is all done. So, type 1 is a type 4 hypersensitivity, upper spectrum, existing lesions, they become prominent and it usually starts on initiation of MDT. Whereas type 2 reaction is more commonly predisposed by fever, pregnancy or something like that. In both the type of reactions, you continue with MDT and you give oral steroids as the first choice. Clear? So, this is briefly about important questions which are asked in leprosy. Moving on to the next topic. I hope the speed is okay, students, and I hope you are able to understand. Okay, what is upper and lower spectrum? Thank you for asking that question, Dr. Jason. Upper spectrum is the tuberculoid pole, BT, TT Hansen. Lower spectrum is the lepromatous pole, BL, LL Hansen, right? So, type 1 reaction is more commonly seen in tuberculoid pole. Why? Because it's a type 1 hypersensitivity. Here, what happens is when you give MDT, the bacilli are killed. And when the bacilli are killed, because my body has good immune response, it reacts against those dead bacilli and that leads to type 1 reaction, whereas type 2 reaction is seen in lepromatous pole where my antibodies are more but my CMI is very low. So, when I have a trigger like fever, some pregnancy or some stress factor, my immune system further goes for a toss leading to sudden increase in the bacilli and that is why I have type 2 reaction. Now, because my antibody response is good, so there are more antigen antibody complexes which are formed in type 2 reaction and that is why it is a type of type 3 hypersensitivity. So, everything has a logic. Please refer to the main lectures. It will become very easy for you if you understand the concepts, right? Good. So, as I was going through that, you all have answered my next question. Very, very good. Yes, in children you can give steroids. Okay, Good. So next question is a 15-year-old, and sorry, I didn't see the responses. So most of you are right, but some of you are getting confused with option C. Okay. So let's discuss this. A 15-year-old girl presented with history of hair loss since few weeks. Otherwise, patient is well, and when you see the site, you see multiple broken hair follicles. So only pointer in this question is this: multiple broken hair follicles. Remember students, if in the question they are saying multiple broken hair follicles with hair loss, think of only trichotillomania. Now, why was there a confusion with alopecia areata? See, even if you look at the image, someone was right. Someone pointed out, can you see these bleeding points? Can you see these hair? Alopecia areata will be smooth. It is a smooth patch. You do not see multiple broken hair follicles on the patch. You see on the surroundings there are few broken hairs, but on the patch you see multiple broken hair follicles only in trichotillomania. Because trichotillomania is a psychiatric disorder, patient pulls or plucks his or her hair. When you pull the hair with an external force, your force cannot be constant. So you would have hair of unequal length. So you'll have broken hair follicles. Alopecia areata, on the other hand, is an autoimmune disorder. There my hair, suprabulbar area of my hair is targeted, and so all the hair are lost. So you do not see broken hair follicles on the surface. You see a smooth patch. I'll just show you the images. So trichotillomania shows hair of various length. Along with that, what can you see? Okay, incomplete hair loss. Just looking at the various questions that you've posted. Okay, so good. So I'm going to deal with all of these questions. So now whenever you have a patient with hair loss, so first of all, divide it into two categories, whether it is non-cicatricial or cicatricial. What do I mean by cicatricial and non-cicatricial? Cicatricial means scarring. So here my stem cells are gone. So the chances of hair growth are minimal. What causes cicatricial alopecia? Most commonly the things that you are given with, it's a long list, but what you should be knowing: LP, DLE and pseudopelade of Brock. Right? Now, when I talk about non-cicatricial alopecias, there can be effluviums, it can be patchy, or it can be patterned. There are three kinds of non-cicatricial alopecia. When I talk about effluviums, the most common one that is given to you is telogen effluvium, where they will give you a typical history that there was some period of stress, pregnancy, prolonged illness, which was 2 to 3 months prior to hair fall, and then the patient started having sudden hair fall. The treatment for it would be biotin and counseling. Done. That is what you need to know about TE. When we talk about patterned alopecia, I'll just show you the images and discuss there. When we talk about patchy alopecia, you have to think of alopecia areata, you have to think of Tinea Capitis, you have to think of trichotillomania, and you have to think of moth-eaten alopecia seen in syphilis. Right. So, I'll quickly tell you how to differentiate between all of this. Yes, TE, there is no treatment. Anagen effluvium is caused by chemotherapy. Great. So, alopecia, all this I will be discussing, just quickly telling you about moth-eaten alopecia. It's seen in syphilis. If they want to ask you this, they will give you other features of syphilis. They will give you VDRL positivity, because moth-eaten alopecia cannot be a standalone finding. Okay. When they are giving you cicatricial alopecia, think of these three conditions. Now talking about the non-cicatricial alopecia. So this is a more clearer image of what I just showed you. So this is a patient of trichotillomania. If you see, the patient will pull out hair from the dominant part of the scalp, And there in the question you may be given some history of psychiatric disturbance or you may not be given a history of psychiatric disturbance. But the most important thing is on the patch you see multiple broken hair follicles of various lengths. There can be perifollicular hemorrhages, there can be hemosiderin deposition, there can be trichobezoar associated with it, there can be even GI obstruction. How do you treat this patient? It is a psychiatric disorders. So, you have to go for cognitive behavioral therapy. You can give SSRIs. Clear? So, this is all that you need to know about trichotillomania. Yes, sorry, Friar-Tuck sign is seen in trichotillomania. Now, what is this Friar-Tuck sign? Friar-Tuck was an important cartoon character who had this kind of hair, and that is why this name has been given to it. So, Friar-Tuck sign, perifollicular hemorrhage, broken hair of different lengths, these are all features of trichotillomania. How do you treat? You give cognitive behavioral therapy and you can give SSRI, right? So, I would want you to restrict your questions to the exam oriented things. If there are, I know in dermatology and about hair, there are a lot of general questions. Maybe we can talk about them later in our normal classes. But today it is a quick, swift revision for important topics. So, as to answer Dr. Sarthak, yes, they are effective, but we will have to talk in more details about that. Okay. Now, coming to this. Now, this is alopecia areata. Look at this patch. It's clean. There are no broken hair follicles. This is also called as spillade or smooth patch. So, you have a smooth patch of hair loss. And on the periphery, you can see some dots or you can even see white hair. So, white hair can be seen on this patch. It is a completely smooth patch. And if you look at the periphery, you see exclamation mark hair. Exclamation mark hair is seen in the periphery of alopecia areata patches, and this is mostly seen with dermoscopy. Alopecia areata can be of various types. What is the etiology? It is an autoimmune T-cell mediated disorder, right? So, how do you treat this? You give intralesional steroids, you can even give oral steroids, and you give contact immunotherapy, right? So, this is all that you need to know about alopecia areata, and the patient can go grey overnight. That is also a feature of alopecia areata because here the target when the immune cells target the hair, they do not target the white hair, and so white hair are retained, all black hair are gone. So, patient can turn grey overnight, right? Now, this is the patterned hair loss that I was talking about. So, this is androgenetic alopecia, can be seen in both males and females. So, what do you see in males? You see this pattern, frontotemporal recession, which happens by temporal recession, balding and vertex thinning is seen. So, this is seen in males. In females, you see that central parting is more visible, and by the grade 3, you have this fir tree pattern. In males, the classification that we use is Hamilton-Norwood classification, and in females we use Ludwig's classification, right? Then what is the treatment here? Because you should be knowing the treatment. Treatment here is minoxidil. We use minoxidil, which is used in the concentration of 2% for females and 5% for males. We also use finasteride in males, and in females you can use anti-androgens. What are the only FDA approved treatment for androgenetic alopecia? It is finasteride and minoxidil, right? So, this is what is usually asked. You are given a patterned hair loss. Here the patient has no symptoms, just that the hair density is going low. Yes, right. Finasteride. Good. So, these are the important questions which are asked in here, right? So, this is the classification. So, you should broadly divide cicatricial, non-cicatricial, and I told you these are the important things. Then what is this? Quickly, what is this and what is this sign? Good question, Dr. Devaki. Why do we give spironolactone in both alopecia, androgenetic alopecia and hirsutism? Because there, in both the conditions, the answer is hyperandrogenism. Now, androgen or testosterone is a weird hormone which has different effect on the beard area and on the scalp. So, if you have hyperandrogenism, you will grow hair on the face. So, females will have hirsutism and it causes thinning of hair on the scalp, and so the patient has androgenetic alopecia. So, androgens have reverse action on scalp and beard, and that is why you use spironolactone, which is an anti-androgen for both hirsutism and for androgenetic alopecia. Good. So, you all know this. No, this is not Christmas tree pattern. This is footprints in snow pattern, which is seen in pseudopelade of Brock. This is a form of cicatricial alopecia or scarring alopecia, which has no cause. It is idiopathic, you have no inflammation, the patient just present with these footprints in snow appearance, and this is a form of cicatricial alopecia seen in pseudopelade of Brock. Clear? So, this is briefly about hair. Moving on to the next question. Patient presented with the following lesion. This is characteristic of what disease? So, here you have to look into the image and think what can be the answer. Very good. Dr. Sarthak, I think we'll discuss that later. That's not the part of this session. Good. So, there is no confusion here. You're absolutely right. This is Gottron's papules. This is dermatitis, dermatomyositis. So, now dermatomyositis again is an important topic. Dermatomyositis, as the name reveals, derma and myositis. So, you have skin features and you have muscle features. Now, when I talk about muscle features, remember in the question they can give you some history of proximal muscle weakness. So, patient will have proximal muscle weakness and associated with it skin features. Now, when we talk about skin features of dermatomyositis, there are two characteristic lesions or two pathognomic lesions, sorry, not characteristic, but pathognomic lesions, which are Gottron's papules and Gottron's sign. So, what are these? So, these are two named things, and we should be knowing about that. So, Gottron's papules is when you see these erythematous two violaceous papules which are present in the interphalangeal joint and metacarpophalangeal joint. Now, the thing about dermatomyositis is you see confluent lesions which can be either macular or papular, and they have a violaceous tinge to it. So, it is also called as confluent macular violaceous erythema. When it is just macules, I call it Gottron's sign. When it is papular, I call it Gottron's papule. So, Gottron's papules and sign is similar thing, just the morphology of lesion is different, and the clinical feature is called as CMV or confluent macular violaceous erythema. So, you would be given proximal muscle weakness, you would be given either of these. So, now this CMV, so when you talk about pathognomic sign, pathognomic is when you have papules and signs, and the location is important. The location is either interphalangeal joint or metacarpophalangeal joint. When these lesions are present at these site, then I call them as Gottron's papules and signs, and this is pathognomic. But you also see other characteristic features in dermatomyositis, the most important of which is asked is heliotrope rash. Heliotrope rash is seen in, they will just give you this. Heliotrope rash is when you see this confluent macular violaceous erythema on the eyelids. So, around the eyes when you see this kind of a rash, it is called as heliotrope rash, which is again a feature of dermatomyositis. And this is Gottron's sign. See, confluent macular violaceous, only erythema. You do not see papules. So, this is Gottron's sign. It is present on interphalangeal and metacarpophalangeal joint. This is the V sign. When you see it on this, there is a shawl sign, there is a holster sign. Dr. Sarthak, you can restrict yourself. If you are seeing PrepLadder videos, they are more than enough for you, because it's more important that what you're reading, you're revising. So if you have multiple sources, you may get confused. We in our videos have covered all the important topics, and so you can refer to those. Perfect. Hair combing sign. Any questions on this? You've written everything. You're all, I think you're all very well prepared. Yes, erythema means redness. So in dermatology, when you see erythema, you mean redness. Yes, we are coming to Holster sign also. I'll show you that also, but clear. So this is Gottron sign when it is present in metacarpophalangeal joint and interphalangeal joint. V sign when it is present on neck. Heliotrope rash when it is present on eyelids. This is my Gottron's papules only. Then this is the Holster sign when I see this confluent macular violaceous erythema on the lateral aspect of the thigh. Then we have Scholl sign. Then you can have mechanic's hand. All these are different skin manifestations of dermatomyositis, and if you look at the nails, you see periungual telangiectasia. So these are all features of dermatomyositis. Clear? When you talk about the diagnosis of DM, there is a Peter and Bohan's criteria in which you have to have characteristic skin lesions, and very, very importantly, you have to prove that the patient has proximal muscle weakness. So in DM, both the features should be present, right? Yes, this LLR videos is enough for passing FMGE. They are good enough, but you should have your base clear. I always feel that LRR videos can help you in quick revision, but since we are not able to make you understand the core topics here, so then you might get confused in the exam. So you should have a base. If you have read basics of dermatology nicely, then for revision these LLR videos are very good enough, right? So I think that was, what was the nail finding is periungual telangiectasia is not commonly asked, so forget about it. Now let's move on to, no, mechanic's hand is a feature of dermatomyositis, not scleroderma. In scleroderma, you see sclerodactyly, don't get confused. In mechanic's hand, you are seeing this hyperkeratotic lesions, just like a mechanic would have, and sclerodactyly is a feature of scleroderma, right? Now, next question, which cell is not present in the shown layer? So, I have moved on to the next topic. Okay. Okay. Now, an important information here, since some of you are saying A, keratinocytes are present in all layers of the epidermis. So, keratinocyte to answer ho hi nahi sakta. What I have shown you here, this is my stratum corneum, this is granulosum, spinosum, and this is the basal layer, and the arrow is pointing towards the basal layer. So, it is asking which cell is not present in the basal layer. Remember, keratinocytes forms the epidermis, so it is there in all layers. You may get confused between the rest of the three, but don't get confused with keratinocytes. And rest you all are right. Yes, this is Langerhans cells. So, very easy to remember. Keratinocytes are present in all cell layers. Both M are present in stratum basal. So, it is the Langerhans cell which is not there in stratum basal, it is present in stratum spinosum. Okay, so these are my 4 important cell layers. Okay, so I am sure you must be knowing about the layers of the skin, I am not discussing that. Corneum, followed by granulosum, spinosum and basal, and in palms and soles I have stratum lucidum, right, which is a layer which is only seen in palms and soles and has refractile granules of elidine, right. So, this is my various layers of the epidermis. Now, coming to what are the different kinds of cells that you see in the epidermis. So, I have 4 cells, keratinocytes, which are present all over the epidermis. So, let us see here. Keratinocytes are present in all layers. They are derived from ectoderm and they form keratin intermediate filaments, which is important for the structure of the epidermis. The next cell that we see in epidermis is melanocytes. Melanocytes are present only in stratum basal. They are derived from, M is derived from N or neural crest. Melanocytes are pigment forming cells, you all know that. They are present. There is something called as EMU. What is the EMU, or epidermal melanin unit? What is the ratio of keratinocytes to melanocytes in an epidermal melanin unit? So, Dr. Harsh, first, second and third degree burns would be dealt in surgery. It's not a dermatology question. Yes. So, my melanocyte transfers its melanin to 36 keratinocytes around it, and this is called as EMU. So, EMU is 1:36. But in the stratum basale, there is one melanocyte for every 10 keratinocytes. So, by distribution it is 1:10, but it is surrounding to 36 keratinocytes around it. Now, these melanocytes are pigment forming cells and they form pigment, right? They are derived from neural crest. Next are Merkel cells. Both M, as I told you, are present in stratum basale. Now, Merkel cells are derived from either ectoderm or neural crest, but if you have to mark one, mark ectoderm. These are slow adapting touch receptors. So, Merkel cells are slow adapting touch receptors, not 1:30, 1:36, and 1:10 is the ratio of melanocyte which are present in the basal per keratinocyte. The third cell that I have is Langerhans cell, which are derived from mesoderm or bone marrow. They are present in stratum spinosum. These are my antigen presenting cell, and they have a special granules which are called as, what is the structure of Langerhans cells? What is the type of shape it has? Burbeck granules, very good. So, you have Burbeck granules here, or which are also called as racket shaped granules. Racket shaped granules. Now, remember, both Langerhans cells and melanocytes are dendritic cells. So, these are different informations which are asked in different forms, and you should be knowing about that. Tennis racket or ye, right? So, these are different types of cells which are present in the epidermis. You are right, in Langerhans cells, S100 and CD1A positivity are also seen. Clear? So, this is about the basics of dermatology. Now, moving on to the next important topic. A man is having multiple painful, non-indurated undermined ulcers over glands which occurred 5 days after sexual exposure. What would be the most likely finding that you see? I am not asking about the diagnosis, I am asking you about the finding that you will see. Okay, so there is a confusion between A and C, right. So, great. Oh, a lot of you are there for C as well. Okay, let me clarify this. So, multiple painful non-indurated undermined ulcer with sloughed edges. Now, obviously you know this is for chancroid. You see this in syphilis, this with herpes, and this with donovanosis. Now, when we say painful, obviously syphilis is out, even, sorry, did I say donovanosis here? I am sorry. What I meant is LGV. So, when I say painful, I rule out syphilis, donovanosis and LGV. So, painful lesions are two, either chancroid or herpes. So, there can be a confusion between A and C. Out of this, non-indurated, both of them, but herpes does not present with undermined ulcer with sloughed edges. Undermined ulcer with sloughed edges is a feature of chancroid. Herpes will present with multiple coalescing vesicles and polycyclic erosions. Rest all the features can fit with herpes. Multiple lesions, painful lesions occurring 5 days after sexual intercourse. This can all go with herpes, but undermined ulcer with sloughed edges is the giveaway thing here. That is seen with chancroid. So, don't get confused between herpes and chancroid. So, though other features are common, but this should be chancroid here, right? So, now quickly revising the different genital ulcers that are asked. I'm sorry, I didn't put herpes here, but I'll discuss it commonly. So, how do you differentiate between the 5 genital ulcers? Look at the pain part. If it is painful, it can be either herpes or chancroid. Then look at the number of lesions. Single lesion. Single lesion is seen with syphilis, LGV, donovanosis. Both chancroid and herpes have multiple lesions. So, mostly herpes and chancroid are two which have very common features. Short contact period, short incubation period, multiple lesions, painful lesions. But herpes will present with polycyclic erosions and vesicles, whereas chancroid presents with ulcers which have undermined edges, right? Usually in chancroid you have unilateral lymphadenopathy, is also called as buboes, whereas in herpes you have bilateral painful lymphadenopathy. So this is the difference between chancroid and herpes, right? Then coming to syphilis, single lesion, painless lesion, indurated lesions with shorty lymph node. All these are important features of syphilis. Single, painless, indurated and shorty lymph node. What will you give? You will give injection benzathine penicillin. LGV. Okay, maybe I have put an image. Good, perfect. So, we will see here. So, what is this? This is my chancroid. Multiple lesions, painful lesions, undermined edges with necrotic slough on top. It does not have a clean base like syphilis. This is also called as soft chancre. It is caused by H. ducreyi. Here you see a short contact period. You have usually unilateral buboes here. And if you do a gram stain, you see this school of fish appearance. School of fish appearance is seen in Haemophilus ducreyi causing chancroid. Right? Clear? Moving on to the next one. Look at the kind of ulcer here. Single, indurated, painless, shorty lymph node. All these are pointers towards syphilis. And what kind of syphilis? Primary syphilis, also called as chancre. And here you would do this dark ground microscopy and you would see these fluorescent spiral organisms. Clear? Clear? Single, indurated, painless, shorty. Now, syphilis is a long topic. Please revise the secondary syphilis features. I could not put here. Treponema pallidum is the organism which causes it. What is this? Now, this is my herpes. You see this? There are numerous vesicles which are coalescing together, giving rise to these polycyclic erosions. Multiple lesions, painful lesions, but not indurated, and they usually do not present with an ulcer. So, if you see an undermined ulcer with sloughed edges, it is chancroid. If you see polycyclic erosions, you have coalescing vesicles, it is herpes. And if you do a Zank smear here, what do you see? You see multinucleate giant cells. You see multinucleate giant cells. This is caused by HSV. Both HSV2 and 1 can cause, but more commonly it is caused by HSV2. Right? It can be primary, secondary or recurrent. And what is this? This is when you see a single beefy granulomatous ulcer. If they give you single ulcer, beefy ulcer, granulomatous ulcer which bleeds easily on touch. So, this is my donovanosis and I have safety pin appearance here. If you do a GIMSA stain, you see this safety pin appearance of microorganism. Right? Clear? Next, what is this? This is LGV. LGV does not present with ulcer. LGV, there is an ulcer, but it is very transient. Usually, the patient will present with buboes, which are very, very painful, which are large, they can be bilateral, and that is how the patients of LGV present to you with. If you examine them, you can see these groove sign where both inguinal and femoral nodes are involved and this Popot's ligament becomes taut. So, this is called as groove sign of LGV. So in LGV you see groove sign and you have buboes, which are painful multiloculated buboes. Yes, clear? So any confusion on genital ulcer, how to differentiate between them, and I hope now there is no confusion between chancroid and herpes, because lot of you gave me answer as herpes genitalis. So if there is anything, please put it in the chat box, I can discuss it with you quickly. Good. Next, coming to the next question, a 26-year-old male came to the OPD with this belly button rash, which is slightly itchy and uncomfortable. What is the potential agent causing this problem? Okay, so there are few questions here and there. Maybe we'll discuss it in the end. So we'll quickly move on because let's cover this. Then I'll discuss the revised leprosy guidelines. Okay, so this is, we'll come to HPV ward, the class duration, another an hour or and a half maybe. Let's see how quickly we can do as much topic as possible. If you guys get bored, we can stop anytime. Yes, this is belly button rash. What causes belly button rash? It is the nickel. So when they are talking about contact allergic dermatitis, remember nickel is the most common metal which causes allergies or contact allergic dermatitis. Now nickel is present in belly buttons, not just belly buttons. It's also present on the this belts. It is present in artificial earrings. It is present on this keychains. They are also present on wristwatch. So any of this can be given to you. This is all nickel causing the menace. So this is an example of contact allergic dermatitis and this is caused by nickel. This is an example of bindi dermatitis. And bindi dermatitis, the contact allergen is called as para-tertiary butyl phenol or PTBP. This is hair dye dermatitis and this is caused by paraphenylene or PPD. So these are the three common contact allergens which are frequently asked in the exam: nickel, PTBP and hair dye. Now you should also be able to differentiate between contact allergic and irritant dermatitis. Irritant dermatitis is usually very sudden. It is not generating an immunological response, so usually happens after the first contact. It can be something similar to an acid burn or alkali burn which you have in the chemist lab. Whereas allergic contact dermatitis happens on subsequent exposure and so it is immunologically mediated. It usually irritant contact dermatitis will only happen at the contact site, whereas allergic contact dermatitis can happen at sites distant from the contact site because it is an immunological response. So these are few important differentiating features between irritant and allergic contact dermatitis that you should be knowing, and then you should be knowing these important allergens and their sources which are commonly asked, right? Hair dye is PPD. Yes, contact allergic dermatitis is type 4 hypersensitivity response. So here you have your next question. So nickel is the most common thing that you see in artificial jewelry and jean buttons. Chromium is seen with cement workers. So a lot of times they give you cement workers. It is chromium which is present in them. Potassium dichromate is seen with painters, with people who are working with leather, detergents and other things. Another important thing that is asked is PPD that we already discussed, PTBP which we already discussed, and then plant-based dermatitis which is usually caused by Parthenium. So plants can also cause allergic dermatitis. The most common plant source in India causing allergic dermatitis is Parthenium hysterophorus, which is also called as Congress grass or wild grass, and the allergen that is there in Parthenium is called as SQL or sesquipterone lactone. Sesquipterone lactone is the culprit here, right? So these are various allergens and their sources. we'll talk about Guttate Psoriasis, right? So, yes. So, when hair dye causes leukoderma, sorry, I didn't get the question here. So, most of it is covered. Okay. Ma'am, can we crack INI-CET if we start today? Yes, you can. If you believe you can surely do it. You have to just start, right? So just focus on the studies. Don't think about whether you started today or not. I'm sure you can crack it. I have lot of examples of people who started a month back and they could crack the exam, right? Because remember, it's not what you're preparing now, what you've been doing throughout your MBBS that's important. So if you studied during your MBBS, your fundas are cleared, you can surely crack it. Now, this is the next question that we'll be talking about. A 12-year-old male who is a kidney transplant recipient presents with multiple brown keratotic papules and forehead and scalp. Which is the common cause here? 6 and 11, why am I getting a lot of A's here? What is the diagnosis here? Okay, let's see. Okay, B, D. So I have all kinds of answers here. So first let me show you this, then I'll come back to the question. Now remember students, I think there's a lot of confusion here. HPV has more than 200 subtypes, right? And there, I don't know why, but examiners are fond of asking you the HPV type causing the particular kind of verruca or warts. So remember this mnemonic: DSP, come eat a burger. So you are inviting a DSP to come eat a burger. So D is deep plantar, S is superficial plantar wart, P is plain wart, C is common wart, E is EDV, A is anogenital wart, and B is butcher's wart. Right? So DSP, come eat a burger, and you write 1, 2, 3, 4, 5, 6, 7. So plantar warts are of two types, deep and superficial. Deep plantar wart is caused by type 1 HPV, superficial by type 2. This is a very common word which is asked, which is called as plain warts or verruca plana. Verruca plana is caused by type 3 and it is also caused by type 10. Then common warts or verruca vulgaris is caused by HPV type 4, 2 and 27. EDV or epidermal dysplasia verruciformis is caused by HPV 5 and 8. Anogenital warts are of two types, low risk, high risk. Low risk is 6, 11, high risk is 16, 18. And Butcher's wart is HPV type 7. If you remember this table, you would be able to answer most of the questions. You have to write 1 to 7 and then DSP, come eat a burger, right? Now let's go back to the question. So what do I have here? I have a patient of verruca plana here. I have plain top lesions which are present. Why is it a patient of verruca plana? Look at this history, kidney transplant recipient. Verruca plana is seen in patients who are immunocompromised, who are on chemotherapy, who are kidney transplant recipient. Yes, so when you have been given in the question an immunocompromised state and lesions on face, these two are important pointers towards verruca plana. Verruca plana is a plain wart which has slightly more planar surface than the normal common wart, which is very hyperkeratotic. Okay, so the most important feature of verruca plana is it is seen in immunocompromised state and it is seen on face, right? So since both of this is present, this is a patient of verruca plana. Now go back to our mnemonic DSP. P was plain wart, so P was 3. So we have HPV type 3 and 10 here. Lot of you were saying A is 6, 11. It is anogenital wart. HPV subtype 2 and 4 both is for common what? 16-18 is high risk HPV type. Clear? So, you should be able to differentiate between verruca plana, verruca vulgaris, and other things are based on the areas, and then you should be able to tell the HPV subtype. Right? Common is 2, 4 and 27. Yes, you are right. Got it? So, there was a lot of different answers. I hope this is clear, and this is a table which you need to remember. Okay? So, let me move on to the next question. A child is a known case of asthma, well controlled on medication. He came to the OPD and physician noticed an important clinical sign. What is the clinical sign here? Sorry, I would not be able to show you different pictures right now, Dr. Siddharth. I do not have that PDF. But you can easily see it online. Absolutely right. So, there is no confusion. I am very glad. So, you are clear about this. Yes, this is atopic dermatitis. Here is a history of atopy, and you can see this extra fold of skin on the lower eyelid, which is called as Denny Morgan fold, which is a feature of atopic dermatitis. Now, please remember the other features which I have put, which is hertoxine, keratoconus, keratosis pilaris are also features of atopic dermatitis. So, these are all features of atopic dermatitis, but what you see in the image here is an extra fold of skin on the lower eyelid. This is called as Denny Morgan fold, and this is a feature of atopic dermatitis. Now, atopic dermatitis is another important question which is asked. First they ask you what kind of, so it's a clinical diagnosis. You do not need any test to diagnose atopic dermatitis. There is a criteria called as Hanifin and Rajka criteria, which is a clinical criteria. It is a diagnosis where you do clinical diagnosis. You do not need a test. And what are the different features of these criteria? Patient will be itchy. The lesions will be chronic, relapsing, remitting, will keep coming and going. Then there will be a personal or family history of atopy. There can be history of asthma, allergic rhinitis or itchy lesions. Then very important, typical morphology and distribution of lesions. If they will give you infants and children, they will give you face and extensor involvement. So, in infants you will see face or extensor involvement. In adults you see flexural involvement, even in toddlers. So, I would say in infants you see extensor involvement, but in toddlers or children you see flexural involvement, and in adults you can even see hands and feet involvement. Right? So, yes, you can say Rajma criteria. So, it's Hanifin and Rajka criteria, very easy, very clinical. So, there will be some history of atopy where they will talk about either of these, and then the important feature here is, this is not all that you need to know. You should just know that it is a Th2 response that's generated here, and the patient can have high IgE, but you do not use that as a diagnostic test, right? Then these are the different features that you see in a patient of atopic dermatitis. This is what I had shown you, Denny Morgan fold or extra fold of skin on the lower eyelid. What is this? You see loss of eyebrows called as hertoxine. And you also see this dermatitis around the eyelids. Hertoxine is loss of eyebrows, mostly in the lateral 1/3. So, you see lateral loss of eyebrows in hertoxine, you can see eyelid dermatitis. Then what is this? This is headlight sign. In the periolar area, sparing the little bit of this area, you see dermatitis. This is called as headlight sign. Then you see keratosis pilaris in these patients. And a very important thing that you see is white dermographism. White dermographism. So, all these are important features of atopic dermatitis. So, clinical criteria, you should know the criteria, you should know about Denny Morgan fold, headlight sign, hertoxine. So, these are some of the important things that you need. Okay, so sorry, I will do that, I will remember that. Thank you for pointing out. Clear? on atopic dermatitis, so you can easily crack this question. Now coming to the next question. A 28-year-old female complains that in the previous 3 to 4 years, her toenails have changed in color, the rate of nail growth has slowed, there are no other complaints. What treatment should be recommended for the most likely diagnosis? So, what do you see here? In urticaria, you have normal red dermographism. When you scratch, the lesions get red. White dermographism is when you scratch, that area becomes white. Yes, black dermographism in metal poisoning. The center to, okay, B, D, B, B, C, B. Okay, is there a confusion here? Okay, so, okay, what's the diagnosis here, by the way? I think you all know, that's why you're giving this. So, this is obviously a patient of onychomycosis. So, I have given you a yellowish discoloration of one of the toenail, and there is history that the nail growth has been slowed. So, you know this is onychomycosis or fungal infection of the nail plate. Now, when we are dealing with the fungal infection of the nail, we have to see whether we have toenail or we have fingernail. So, treatment of onychomycosis is important. Now, before that, we all know that onychomycosis is of 4 types. The most common is distal lateral subungual onychomycosis, which is the most common. Then we have proximal subungual onychomycosis, which is seen with HIV patients. Then we have superficial white onychomycosis, and then we have total dystrophic onychomycosis. How do you differentiate onychomycosis from psoriasis nail? That is also important. So, psoriasis, you will have pits, you will have oil drop sign, and you will see KOH to be negative. So, these are 3 important features which helps to differentiate onychomycosis from psoriatic nail. Now, you should be knowing the treatment of onychomycosis. So, you usually can go for topical treatment if it is a single nail, but mostly for your thing, we will remember the systemic treatment. Now, in systemic treatment, we can either use itraconazole, we can use terbinafine. Now, the preferred thing that we use these days is pulse therapy. So, in pulse therapy, I'll go back again. When we talk about oral medications, so in itraconazole, we give 100 milligram twice a day or 200 milligram once a day. We give it 2 months for fingernails and 3 months for toenails. Terbinafine is given in the dose of 250 milligram daily. It is given 6 weeks for fingernails and 12 weeks for toenails. So, remember terbinafine 250 milligram daily, 6 weeks and 12 weeks, right? Itraconazole 100 milligram BD 2 months and 3 months. If we need to give pulse therapy, we give higher doses for 1 week every month. For fingernails, this is 2 to 3 pulses, and for toenails, it is 4 to 5 pulses. Clear? Now, let's move on to the question. So, will we give mild steroids? No. Will we give topical terbinafine? No. So, now the only 2 options that are left with me are oral terbinafine, which can be given for 6 weeks or 3 months. Now, remember, here the picture is of toenail. So, for toenail, the duration is 12 weeks, which is 3 months. So, the answer would be option D here. If I had fingernails, I would have given 6 weeks. Is it clear? So, the answer would be D, not C or any other answer. So, first you need to differentiate onychomycosis and psoriatic nail. Then you have to see whether toenail is given or fingernail is given. Accordingly, you decide on the duration of therapy. Terbinafine is always the first line of drug as compared to itraconazole. Why is that? Because it's much safer, it has lesser side effect profile. But if in the question they are giving you molds or candida, in those cases itraconazole becomes my first choice of therapy because terbinafine does not work for molds and candida. Clear? So, that is how you know decide. So, even if itraconazole was given and they had not mentioned molds or candida, then you will mark terbinafine as the drug of choice. So, remember this DOC is terbinafine. Then when do we prefer itraconazole? When we have molds or candida. Now, coming to the topical application. So, topical treatments are also being used, especially if you have single nail involvement. There I use nail lacquers. Two nail lacquers are commonly used, cycloperoxylamine and emerolfin. Emerolfin is given weekly and cycloperoxylamine is given daily. Now, there are two more newer agents which have been introduced, and you should know the name because they have been asked. So, what are the newer agents? They are, any idea? Anyone has any information on the new thing? Yes. So, newer agent are tavobarol and efinaconazole. So, just remember these two names broadly. Somewhere they had asked about tavobarol once. So, these are the two newer agents which have been introduced in onychomycosis. Clear? So, this is what you need to know about. Yes, tavobarol and efinaconazole. So, moving on to the next topic. Good, good. So, you know about this, you should remember this. Tuberculosis are type of cutaneous TB. Which statement is incorrect for these same? So, we all know tuberculosis are a form of cutaneous TB. They are more of hypersensitivity reaction to the persistent bacilli in the body. So, let us move on to the next question, all of you. Please look at the question which is incorrect, not the correct statement. Right. So, the incorrect is low CMI, so Montus is negative. So, quickly revising, what are tuberculosis? Tuberculosis are basically, so remember this, hypersensitivity reaction. How to solve this kind of question? Which kind of question are you talking about? You are talking about this tuberculosis question? Okay. So, I'll quickly talk about tuberculosis. So, tuberculosis are basically hypersensitivity reaction against the remnant bacilli or present bacilli, tubercular bacilli in the body. So, here what happens, there is a type 4 hypersensitivity reaction which is generated. Now, if a type 4 hypersensitivity reaction is being generated, that means my CMI is good. So, in tuberculosis my CMI is good, and so my Montus would always be positive, right? Now, here the focus of TB is elsewhere, right? That is why my body is mounting a CMI response which is being manifested in skin. So, my focus of TB is elsewhere. So, since the focus of TB is elsewhere, if you do a skin biopsy, that skin is manifesting the hypersensitivity reaction. So, you do not see AFB there, or you do not see AFB on culture. However, since the hypersensitivity reaction is because of TB bacilli hypersensitivity, you see tuberculoid histology. So, histology is tuberculoid, but you do not see AFB. And since it is a hypersensitivity reaction against TB bacilli, it responds to ATT. Clear? So, it is quite simple if you understand what are tuberculoids. So, if you remember this, you know, and you can mark that low CMI, so Montus is negative is wrong, because here the CMI is good, and that is why hypersensitivity reaction is being generated. Got it? So, Dr. Samreen, is it okay? Do you understand this now? Now, when we talk about tuberculosis, you should know also the type of tuberculosis. So, you have three main type of tuberculosis, and you should be knowing two mainly, which is lichen scrofullosorum. This is lichen scrofullosorum. Lichen scrofullosorum is something that you see in children. Important points. You see it in children, you see it on trunk, you see perifollicular lichenoid papules. So, around the follicles you see perifollicular grouped lichenoid papules which are present on the trunk of children. And if you do a biopsy, you see superficial dermal granulomas, right? So, this is my lichen scrofullosorum. It is a type of tuberculate. What is this? This is another type of tuberculate called as papulonecrotic tuberculate. This is seen in adults. So, I will only tell the differences. This is seen on adults. It is not seen on trunk but on extensors. Here you see necrotic papules as the name suggests. So, on the extensors of adults you see necrotic papules, right. The third type is called as erythema induratum of Bazin. Now, this is a facultative tuberculate. What do you mean by true and facultative tuberculate? True tuberculates are those which are caused only by MTB. Facultative tuberculates can be caused by others also. So, erythema induratum of Bazin, this is important because here you see it in posterior aspect of calves and you see it in post-menopausal females. Now, you should be able to differentiate between erythema induratum of Bazin and erythema nodosum. Remember, erythema nodosum never ulcerates or scars, and this is seen on anterior shins. This is seen in posterior calves, postmenopausal females, and this can ulcerate or scar, whereas erythema nodosum never ulcerates and scars. So, this is another important question that is asked sometimes, right? Good. So, this is these are different types of tuberculates. Moving on to the next question. A farmer from UP came to the OPD with ulcerate. I don't know, this is a very common question that is asked in almost all the exams. So, I decided to put it. I am sure you all know this, but this is important to discuss. So, a farmer from UP came to the OPD with ulcerating nodules on hand with pus discharge from the same. Slowly progressing, and you see regional lymphadenopathy, and a histopathic examination was ordered. What is the most probable diagnosis here? I don't see any confusion here. So, I know you all are well read about this. This is sporotrichosis. Sporotrichosis, quickly discovering. No copper penny here. Where do you see copper penny bodies? No confusion. These are asteroid bodies, not copper penny bodies. Copper penny bodies are seen with what? You only tell me. Chromoblastomycosis, right? So, what you see here? You are seeing nodules which are arranged in linear distribution. So, sporotrichosis, the characteristic feature is you see painless nodules which may be ulcerated present along the lymphatics. This is also called as the sporotrichoid pattern because of its characteristic spread. Because my lymphatics are linear, you see linear painless nodules along the lymphatics and sporotrichosis. Now, sporotrichosis is a deep subcutaneous fungal infection. So, it is a subcutaneous fungal infection, remember, caused by Sporothrix kenkai. Sporothrix kenkai. This is also called as rose gardener's disease because usually it is seen in rose gardeners. They get thorn prick, and from that the fungus is implanted into the subcutaneous tissue. However, it can also be seen in farmers. There was a question recently on this. They have not given rose gardener, but they had given a farmer. So, farmer can also have it, right? So, but it is called as rose gardener's disease. Then if you do a histopathology, what you see asteroid bodies which are nothing but fungus which is being surrounded by immune cells from all sides, giving rise to asteroid bodies here, right? How do you treat? You give itraconazole, you can give potassium iodide, and you can even give terbinafine. So, in sporotrichosis, everything is important. Remember, asteroid bodies are formed because of Splendor-Hopley phenomena, and these are not specific for sporotrichosis, but you very commonly see it in sporotrichosis patients, right? Somebody mentioned copper penny bodies, that is seen with chromoblastomycosis, that is another subcutaneous fungal infection where we see verrucous plaques, and these bacilli, they appear like copper penny or sclerotic bodies, right? Then this is my asteroid bodies that you see. So, sometimes they just give you this. Then even if you perform a PAS stain in these patients, you see these cigar shaped bodies, right. So, Sporothrix kenkai or sporotrichosis is very, very important. They have a question on this topic almost in every exam. Clear? Now, so moving on to the next question. Clear? Any questions related to this we can still discuss? Okay. Now, a 50-year-old male presents with solitary ulcer over face since 2 months. You see a solitary ulcer which has a beaded margins and telangiectasias. Again, a very common or famous question with the examiner. What is the diagnosis here? Good. So, I think there is no confusion here. All of you are saying it's basal cell carcinomas. Remember, this is what they ask. Basal cell carcinoma, they give you an image which is there around the eyelid. So, remember BCC, this is a very common site. So, from the area of the nose, if you mark a line here, it is usually above this. So, you see BCC here, and the typical description of ulcer is it's a long standing ulcer with beaded margins and with telangiectasias. So, beaded margins and telangiectasias are important feature of BCC. What do you see on histopathology of BCC? Come on, quickly. Histopathology of BCC. Of BCC and SCC. There are two histopathologies that you should be knowing. Yes, BCC is also called as rodent ulcer. Yes, so in BCC you see palisades which are very, very common. So, basal cell palisading is something that you see. What do you see in SCC? SCC, what do you see in squamous cell carcinoma? Keratin pearls. So, this was also asked once. So, on histopathology of SCC, you see keratin pearls, and here you see palisades of cells. What is this? Since we are talking about skin tumors, if you are given a picture like this, what is the diagnosis here? Let's see. Oh, this is not a melanoma. Please, I'll show you a melanoma. Is it really an SCC? What do you see here? You are seeing a dome shape. I'll describe the lesion for you. It's a dome shaped lesion filled with central keratin plug. It is a type of well differentiated SCC, but yes, it has a particular name to it. This is keratoacanthoma. Keratoacanthoma is a type of well differentiated SCC, but when you are given this image, you say keratoacanthoma. You see this dome shaped lesion and a center filled with keratin plug. It's a very weird tumor. It grows and then the sides, they merge with the skin, this keratin plug falls off and it goes off. So, you should be knowing about keratoacanthoma and how does it look like. And this is how a malignant melanoma would look like. This is never a melanoma, okay. So, don't get confused. Malignant melanoma would present mostly, if they are giving you a question, there is a melanotic one, but if they are giving you a question, they will give you a pigmented lesion which shows various degree of pigmentation. How do we diagnose a melanoma? What's the rule of diagnosing a melanoma? So, yes, this is a malignant melanoma and we use A, B, C, D, E rule to diagnose a melanoma, right. You look for asymmetry, border, color, diameter and evolution of the lesion to diagnose a melanoma, right. So, these are some of the important tumors which have been asked, right. Moving on to the next important question. A 6-year-old presents with intense itching, bald patch with easy pluckability of hairs with black spots on the scalp. Which is the most appropriate pharmacotherapy that you will use here? Now, looking at the options, I don't think so there is any confusion on the diagnosis here. Yes, we are dealing with Tinea Capitis, but I want you to tell me that what is my drug of choice for Perfect. So you all know this. So griseofulvin is the drug of choice for Tinea Capitis. Remember, we are hardly using griseofulvin these days, but for Tinea Capitis, it still remains the drug of choice. So all these are also utilized in Tinea Capitis, but my drug of choice is griseofulvin. Second important point, do we need these selenium sulfide shampoos? Yes, but they are not for treatment, they are to prevent the spread to the community. So Tinea Capitis is always treated with oral treatment. We use topical shampoos just to prevent the spread to the community, but my treatment of choice is griseofulvin. So since we are talking about this, we will quickly walk through the various kinds of Tinea Capitis. I will discuss each one in detail. So broadly, Tinea Capitis is divided into inflammatory and non-inflammatory. In inflammatory, we have two, chorion and favus. When we are talking about chorion, remember you have boggy swelling. You have boggy swelling, which is studied with pustules and broken hair. You have a patch of alopecia in all of them, but there is a boggy swelling, which is a characteristic feature of chorion. Then the patient may have fever, constitutional symptoms. The common fungus which causes chorion is ferruginum and verrucosum. Long names. Severe kind of Tinea Capitis, long name. When you do a KOH cultures and wood lamp examination, it is negative. Why? Because there is so much of inflammatory response that the fungus is actually killed, and it is the inflammatory response of the body which is causing this chorion. Why is it so? Because both these verrucosum and ferruginum are zoophilic species. They are not anthrophilic, so my body mounts an intense immune response against that. Clear? Then the next inflammatory type of Tinea Capitis is called as favus. Favus is special because one, it is caused by Trichophyton conleni. What do you see here? You see cup-shaped crust which are called as scutula. You see these cup-shaped crust which are called as scutula. If you do a Wood's lamp, you see dull green fluorescence here, right? Then the third type of Tinea Capitis which is commonly asked is grey patch type of Tinea Capitis. As the name suggests, along with the circular patch of alopecia, you see grey scales over them. You see grey scales and broken off hair. This is an ectothrix infection. That means the fungus is invading from outside, and that is why you are seeing scales on the surface. And since you are seeing fungal scales on the surface, if you do a fluorescence, it would come out to be positive. So you do not need to remember everything. Just understand grey patch yani grey scales. Scales means fungus. Fungus is outside, so it's an ectothrix infection. And if fungus is outside, you do a Wood's lamp fluorescence, it would show a positive fluorescence with bright green fluorescence. Again, since the scales are outside, they can spread to other people. So this kind of Tinea Capitis is responsible for outbreaks in school. Clear? Caused by Microsporum canis. Okay, next is black dot. Yes, you are right. If Tinea Capitis is secondary to Trichophyton, we usually prefer terbinafine. Good. Then last type of Tinea Capitis is black dot. Name suggests black dot. What are these black dot? These are swollen hair shaft. Why is my hair shaft swollen? Because my fungus has invaded inside the hair shaft. So it is an endothrix infection. The fungus is inside the hair shaft. Now since it's inside the hair shaft, if I do a fluorescence, there is no fungus on outside, I would see a negative Wood's lamp fluorescence here. Since it's endothrix infection, my species are Tonsurans, Voilatium and Pseudonis. You can remember it with the mnemonic TV. TV is inside the house, so Tonsurans and Voilatium. What do you see here? You see a patch with black dots. Clear? So these are four important type of Tinea Capitis which you should be able to differentiate on the basis of Wood's lamp. You should know their species, you should know their presentation. Clear? Okay. What is this? A 50-year-old male presented with history of HIV and red raised lesions on the palate. What is the given disease? Good. So again, a very important and a common question which is asked in your exam. Yes, this is Kaposi Sarcoma. What is the virus which causes Kaposi Sarcoma? Which virus is responsible for Kaposi Sarcoma? So, Kaposi sarcoma is tumor of endothelial cells of the vessels and is a very common tumor that you see in HIV patient, and it typically presents with deep vascular nodules which can be there on skin or mucosa. You are all right, the causative organism here is HHV8, and this is also been called as Kaposi Sarcoma herpes virus. Kaposi Sarcoma herpes virus because it causes Kaposi Sarcoma. So, this is all that you need to know about Kaposi Sarcoma. You see these deep dermal nodules, it is looking very vascular. So, this is Kaposi Sarcoma, tumor of endothelial cells of vessels seen in HIV positive patients caused by HHV8. And remember, it can be there also on skin, it is just not on mucosa. Sometimes they will give you the similar lesions on skin, that is also Kaposi sarcoma. Now, there is another important condition that is given to you which is seen in HIV positive patients, which is this. What is this condition and what causes this? Quickly. The hint is it is seen in HIV positive patients. Good, very, very good. This is oral hairy leukoplakia. Again, a very important condition given to you in HIV positive patients. This is caused by Epstein-Barr virus or EBV virus. What do you see on the lateral border of the tongue? On the lateral border of the tongue, you see these whitish thready projections or hairy projections. So, this is oral hairy leukoplakia. This is what will be asked in the exam. So, you should be able to identify this condition and the virus causing it. Okay, right. An obese female presents with acne on face. Even after taking medication, her acne is not getting better. So, if you have a patient of acne who is obese and not responding to treatment, what will you think about? Absolutely, you think about hormonal acne. So, if the profile is obese, not responding to treatment, then you think about hormonal acne. Now, pointers towards hormonal acne are lower face involvement, associated seborrhea or overactivity of sebaceous gland, if there is associated female pattern hair loss or in males AGA, but then what else? Hirsutism. If you have any of these conditions, obese patients not responding to treatment, think of hormonal acne, get the hormonal evaluation done, and one of the most important reasons for hormonal acne is PCOS, because there is hyperandrogenism which is mostly responsible for these conditions. In this, you have to diagnose the patient's hormonal issue, which is usually PCOS, and you treat these patients with hormonal treatment and metformin. Please remember this. Okay, so their acne, otherwise the drug of choice is isotretinoin, right? But if the patient has hormonal acne, you have to give metformin and hormonal therapy, right? We will come to hidradenitis suppurativa. Okay, yes, you are right. So, there are certain syndromes which are linked with it called as Saha syndrome, where you see seborrhea, acne, hirsutism and androgenetic alopecia, which I already told you. Here you give this. Now, when we talk, since we are talking quickly about acne, you know there are different grades of acne. You should know the drug of choice of specially type 4 or grade 4 acne, which is nodulocystic acne, is isotretinoin. Now, there is some thing about isotretinoin that I want to mention here. There was once a question in isotretinoin that if you have a childbearing age group patient and she has severe nodulocystic acne, can you give isotretinoin, yes or no? A woman of childbearing age group has nodulocystic acne, would you treat with isotretinoin or not? Yes or no? So, mole nose. Okay, answer is yes. I did not say it's a pregnant patient or a patient who's trying to conceive. I just said a woman of childbearing age group. You can definitely give isotretinoin in these patients along with counseling for contraception alert and 2 UPTs negative. So please remember, this is how they confuse you in the exam. Acne usually happens in childbearing age group. Right. So if you have a teenage girl, she can bear a child, right? I said childbearing age group. Age group is somewhere you can allow isotretinoin, but you have to make sure that there are 2 UPTs negative and you are giving contraception advice to the patient, right? So it can be given. Don't get confused and don't just chuck out isotretinoin, right? However, if the question says a patient who wants to conceive, then isotretinoin is strict no. Clear? I hope this is clear. So, the gap that should be kept between discontinuation of isotretinoin and planning a pregnancy is 3 months. Some books says 1 month, but some books also say 6 months. So, we say it should be 3 months. At least 3 months gap should be there between stopping of isotretinoin and planning a pregnancy. Right? I hope it's clear now. So, don't yes, you're all right. Okay. So, isotretinoin, the most important side effect is teratogenicity, but there are other side effects also. This is what I needed you to know about acne. Now, moving on to the next question. Which of the following is the first change to occur in psoriasis? So, obviously, I have mentioned all the histopath findings in psoriasis, and as you could see in the options, all of them can happen as histopathological change. But what is the first change that will occur? Okay. So, remember the first change, the psoriasis, what is the main problem? It is the inflammation. Where will the inflammation come from? It will come from blood vessels. Where are the blood vessels? They are in the dermis. So, my first change is suprapapillary thinning. If this is my epidermis, my first change starts here because the inflammation will target this area first and then go up. So, usually when we study the histopathological changes, we study from top to bottom, but you have to remember that the change will occur because of inflammation coming through blood vessels, which will be there in the dermis. And so, my first change is suprapapillary thinning. Clear all of you? I hope you have no confusion here. So, all these histopath changes are seen, but first change is suprapapillary thinning. Right. Now, look at this image and quickly let's revise the different histopathological features from top to bottom. We will revise the features from top to bottom. So, in stratum corneum, what is the most important feature? You see parakeratosis and you see hyperkeratosis. Parakeratosis is retention of nuclei and this is a feature of psoriasis. Also a feature of arsenical keratosis. Parakeratosis is seen in and they give you this question, so arsenical keratosis. Then what happens to stratum granulosum? Stratum granulosum is absent. Stratum granulosum is absent. What happens in stratum spinosum? Stratum spinosum shows acanthosis and Kogo's spongiform pustules. Sorry, I forgot to mention in stratum corneum, you also see Monro's microabscesses, right? Stratum spinosum, you see acanthosis and Kogo's. So, you should know this also. Both Kogo's spongiform pustules and Monro's microabscesses are neutrophilic microabscesses that you see in psoriasis. But their location is different. Kogo's is in stratum spinosum and Monro's microabscesses is in stratum corneum. Clear? Then what do you see? You see elongated, club-shaped rete ridges. Elongated, club-shaped rete ridges, which is also called as camel foot appearance. Camel foot appearance. So, if you look at the rete ridges, they are broad, they are elongated, they are club-shaped. This is camel foot appearance. Then you see in the you see suprapapillary thinning. You see dilated blood vessels in the dermis. So, these are all changes in the dermis. So, these are important features of histopathology in psoriasis and we should be aware about them. Clear? Any confusion? And I hope now you're clear that the changes start in the dermis. Yes, you're right. Potrier's microabscesses is a feature of mycosis fungoides and it is a lymphocytic microabscess. There you see mostly lymphocytes. Another microabscess is seen in bullous pemphigoid where you see eosinophilic microabscesses. Clear? Okay, someone was asking me about this. So, it's here. What is this? I'll give you a brief history. A child presented with small erythematous lesions predominantly on the trunk which started after a sore throat which happened 2 weeks ago. Good. So, Guttate psoriasis was something which someone wanted me to discuss. This is also very commonly asked. It is a morphological variant of psoriasis which you see mainly in children. And the most important thing is you are given a history of streptococcal infection. This is seen on trunk. You see multiple small lesions. Unlike psoriasis which has very indurated scaly lesions, you have multiple small slightly scaly lesions, right? And here the treatment is antibiotics, right? You give antibiotics here. You can even go for tonsillectomy and you use antibiotics for the treatment. Yes. Yes, you're right. Psoriasis is usually non-itchy. It's mostly non-itchy and has erythematous, scaly, indurated plaque and scales are typically silvery white in color. Okay. Now, next question in psoriasis. Which kind of psoriasis? Psoriasis, you never give oral steroids. Remember this. But which is the kind of psoriasis where you give oral steroids as treatment of choice? Quickly. Yep, this is also called as raindrop pattern. So, my question was yes. So, when you have all answered. Oh, somebody said herpes gestationis. What is herpes gestationis? Good. So, you're all right. Impetigo herpetiformis is something which is a pustular psoriasis of pregnancy is somewhere that you give oral steroids. What is herpes gestationis? So, please remember herpes gestationis is not same as pustular psoriasis of pregnancy. I want you to answer what is herpes gestationis now. You're all right, pustular psoriasis of pregnancy, impetigo herpetiformis. Herpes gestationis is when you have bullous pemphigoid in pregnancy. That is different from pustular psoriasis in pregnancy. So, please don't get confused. Bullous pemphigoid in pregnancy is called as herpes gestationis. It's not a type of psoriasis. Right. This is a misnomer. It's not herpes. You're right. Moving on to the next question. A 39-year-old female, known case of Retter's disease, was referred to hospital for further evaluation. She is non-smoker, does not use illicit drugs. Vital signs are normal, which is not, I'm so sorry, it should be male. I'm really sorry. So, please reread the question as male. A 39-year-old male, known case of Retter's, he is a non-smoker and which is not the finding of Retter's disease here. Yeah. So, why did I change to male and not female? Because obviously, if it was female, I would not even say succinate balanitis. So, that was the catch there. So, here the answer would be C, subcutaneous nodules, which is not a feature of Retter's disease or reactive arthritis. Rest all three are seen with Retter's disease, right? Yeah, you're all right. So, that's why I changed the question from female to male. Otherwise, I would have been in soap. So, reactive arthritis, you all know it is caused, it's also known as Reiter's disease. It's very commonly seen in HIV positive patients. It's usually preceded by either a GI infection or an STD. It's a chlamydial infection, right? So, here you see polyarthritis, urethritis and non-gonococcal conjunctivitis, and these are the two important skin features that you see in Reiter's disease, which is commonly asked. This is called as keratoderma blenorhegicum when you see hyperkeratotic lesions on the palms, and this is called as cercinate balanitis where you see circular erosions on the glans penis. So, these are two important features of Reiter's disease that you should be knowing. So, subcutaneous nodules are not a feature of Reiter's disease, but polyarthritis, urethritis, non-gonococcal conjunctivitis and these two skin features are. Clear? Now, usually Reiter's disease is also seen in HIV positive patients. When you have a patient of reactive arthritis with HIV, the treatment of choice becomes acitretin. Remember, in HIV positive patients, even if it is psoriasis, the treatment of choice is acitretin and not methotrexate. Please remember this important question. Blenorhegicum and syphilis ke hands ko. Okay, so syphilis is not this hyperkeratotic. Remember, syphilis mein you will have a dusky red or hyperpigmented, usually macules on palms and soles, right? Here you have very, very hyperkeratotic lesions. Plus, there would be other features which would also be mentioned. Whenever they are giving you hands of syphilis, you would see small macules which are hyperpigmented. Okay. Which of the following skin findings is typically associated with Bonneville's disease? So, which is, So, for this we also need to know what's Bonneville's disease. What's Bonneville's disease? We are about to finish the class, I think another 10-15 minutes. Okay, A, B, D, everything is coming on. So, what is Bonneville's disease? Yes, tuberous sclerosis is Bonneville's disease. TSC complex or tuberous sclerosis is called as Bonneville's disease. Then important feature of Bonneville's disease or TSC is angiofibromas. Cutaneous angiofibromas are important feature of Bonneville's disease. So, that was the catch here. Sometimes they ask you feature of two main genodermatosis. So, quickly discussing that. So, these are cutaneous angiofibromas which are seen with tuberous sclerosis patients. They are usually present at 3 to 4 years of age, but they will increase during puberty and they appear as these red papules which are present in the nasolabial distribution. Right? So, this is my angiofibroma. When we talk about tuberous sclerosis, there are few other features that you see which are also part of TSC. So, you see these ash leaf macules, you see these shagreen patch which are very, very leathery. These are also called as collagenoma or shagreen patch. And you see these periungual fibromas which are called as Keenan's tumor. So, basically tuberous sclerosis is all about tubers or growths or hematomas. So, you see a lot of growths here, right? Now, there is a, for tuberous sclerosis we also use this epiloia. So, epilepsy, low intelligence and adenoma sebaceum or cutaneous angiofibroma. Now, remember adenoma sebaceum is a misnomer. There is no sebaceous gland involved here. These are basically cutaneous angiofibromas, but they are labeled as adenoma sebaceum. Clear? So, these are all important features of tuberous sclerosis, and this is what I was telling you. Tuberous sclerosis is all about growths or hematomas. So, you see different kinds of hematomas here. Patient can also have seizures, astrocytomas, optical hematomas, rhabdomyomas and the skin features that I mentioned. Since we are talking about this, we will quickly talk about the other genodermatosis that is commonly asked, which is neurofibromatosis. So, neurofibromatosis, you should be knowing the features. and you should be knowing the criteria for neurofibromatosis. So, here you see multiple neurofibromas, you see cafe au lait macules. Remember, cafe au lait macules can also be seen in tuberous sclerosis and lot of other genodermatosis. So, it is the number and size of CAMs which comes into the criteria of neurofibromas, right, which we will just discuss. And these are optic gliomas that you see, right. So, this is the diagnosis of NF1, and you should know that you should have more than equal to 6 CAMs, which should be of size more than 5 mm in prepubertal and more than 15 mm in prepubertal individuals, postpubertal individuals. So, this is important. CAMs can be present in normal individuals also. 1 to 2 CAMs can be present even in normal individuals. Then you can have axillary inguinal freckling. Axillary freckling is also called as crow's signs. If you have neurofibromas, there should be more than equal to 2, and but if there is a plexiform neurofibroma, you can even have 1. Optic glioma, leash nodules, sphenoid dysplasias, and a first degree relative with NF1. These are different criteria for NF1, and you can remember it with the mnemonic CAFES, from cafe au lait spots, CAFES. So, C for cafe au lait spots, A axillary inguinal freckling, fibromas, I hematomas, and skeletal abnormalities. This is something which you need to remember, but if you have seen the pictures, it would be easy for you, right? So, for neurofibromas also, there is a new drug which is called as pirfenidone, which is now available, which we are using. So, just a new medicine which has come and which you should be knowing. Okay. Now, based on the provided image, what is the most likely causative agent responsible for the skin lesion? Okay, I will try to discuss the kits in the end, yes. So, what is this condition? You are all right, this is Borrelia burgdorferi, a feature of Lyme's disease. In Lyme's disease, you have something called as erythema chronicum migrans or ECM, and this is caused by Borrelia burgdorferi. So, here this is I've written everything here. So, it's ECM or erythema chronicum migrans seen with Lyme's disease. Borrelia burgdorferi is the vector is ixoid ticks, and typically it will present with a central punctum and an expanding lesion. So, you see a central punctum and you see an expanded lesion. This is characteristic of ECM caused by Borrelia burgdorferi, which is caused by a vector called as ixoid ticks and is a feature of Lyme's disease. Clear? Easy one. No, this is not target lesion. Where do you see target lesion? Don't get confused now. Target lesion is seen with, I don't remember the exact prevalence, maybe my PSM colleague would remember, but yes, not so common. Yes, so don't say it as target lesion. So, this is not target lesion. Target lesion is something that you see with erythema multiforme. Remember, dermatology is all about terms and we cannot confuse. Okay. So, erythema multiforme is something which present with target lesions because it has typically 3 zones, and erythema multiforme is seen with viral infections like HSV and mycoplasma and with drugs. Clear? Good. 30, I think we have 2-3 more questions left and then we should be finishing this and we will see what we can discuss. A 30-year-old woman presents with complaints of itchy skin in her underarms and around her nipples. You see small skin colored to yellowish papules. The condition worsens during periods of increased sweat production. What is the most likely diagnosis? Oh my God, all A's. Look at the question carefully, guys. We have lesions in a 30-year-old female which is there in underarms and around nipples. They are itchy, they are not painful. They are skin colored and yellowish papules and they increase on sweat production. So, we are talking about Fox-Fordyce disease. Yes, Fox-Fordyce disease is also called as apocrine miliaria. So, this is a disorder of apocrine gland which is seen in usually postpubertal females. You have these yellowish to skin colored papules which are seen in sites where we have apocrine glands, which is axilla, around nipples, and since it's a type of sweat gland, it would usually increase during summer seasons in areas in times of sweat. It can be itchy or asymptomatic. So, this is called as Fox-Fordyce disease or apocrine malaria or a disorder of apocrine gland. Fordyce spots are on lips. Yes, you are right. Clear? So, please don't get confused between this and this. Now, this is your option A, which is hidradenitis suppurativa. If I had to ask you this, I would give you an obese patient, smoker, alcoholic, presenting with painful lesions in these sites. So, I have pain, I would say there are painful papules, painful nodules, and they are bursting out and they are healing with rope or bridging scars. So, this is my HS. This is also a disorder of apocrine gland, but the presentation is different. Clear? Hidradenitis suppurativa is also something which is commonly asked. You have chronic, recurring, painful papules, nodules, abscesses, healing with bridging scars in obese, diabetic, smoker, alcoholic, any of these conditions. Yes, there are pseudocomedones also, or polyporous comedones as we call them. Clear? Okay. I think that should be the last question. Match the following Woods lamp examination. Now, Woods lamp is something easy but commonly asked. So, quickly, I think it would be difficult for you to answer this. So, I will say erythrasma, you see coral red fluorescence. Erythrasma is caused by Corynebacterium minutissimum, and this on Woods lamp gives coral red fluorescence. Pityriasis versicolor will give a yellowish fluorescence. It will give a yellowish fluorescence. Tinea Capitis, greenish fluorescence. Vitiligo gives milky white fluorescence. So, what's wood lamp? It's a low output mercury arc lamp. There's a wood filter on it which is formed by barium silicate and 9% nickel oxide. It emits wavelength in 320 to 450 nanometer, but the peak is at 365 nanometer. So, these are things that you should be knowing about in Woods lamp. Clear? So, I think that was the last question. Someone wanted me to discuss the kit. So, I will quickly briefly tell you. So, I do not have the image here, but there is a mnemonic that I usually use to remember this. Great girls won't, sorry, this is different, buy red, yellow bags. So, if you remember this mnemonic, most of it can get covered. Great girls won't buy red, yellow bags. So, my first kit is grey, okay. Then it has T and G. So, T and G is gonorrhea and trachomatis. Gonorrhea and trachomatis. What does Neisseria gonorrhea and chlamydia trachomatis cause? They cause urethral discharge. So, if you have a urethral discharge patient, you will give a grey kit, great. Second is girls. So, girls is G for girls, G for green. Now, since it is girls, it would be a kit for vaginal discharge, right? Vaginal discharge kit. I will talk about the drugs which are there, but this is how you remember. Now, won't is white. So, this is seen in white. White, where what do you write on whiteboard? You write A, B, C. Okay. You write A, B, C. So, you have here, what do you have in white, white one? Let's talk about white one. Okay, I think all of you have different mnemonics to it. Yes. So, here you have azithro, you have chancre, right. Then B is blue, R is red. So, red is red, it will deal with herpes genitalis. Yellow is low, so lower abdominal pain, yellow color. Now this is kit 6.1 and kit 6.2, you use it for females, you use it for males. Bags is black, used for buboes. Okay? That's right. So I'm really sorry, if I had the image, I would have explained you better. But this is how I remember great girls won't buy red yellow bags, and you can remember the mnemonics with this. So if there is urethral discharge, ideally urethral discharge, how do you treat? You can give injection ceftriaxone if it is gonococcal, and you add azithromycin. But in kids you cannot give injectable, so you give azithromycin and cefixime. For vaginal discharge, you will use secnidazole, tinidazole. So again, it will also, they usually don't ask you the drugs in the kit. They will give you a clinical scenario and ask you what drug will you use. Okay. So if it is a red kit, you would use acyclovir. If it is a yellow kit, you will use for lower abdominal pain. For bubo, black kit, there is inguinal bubo. Right. So yes, brown kit is also added. That's a new update. That's true. Okay. So any other questions, or we will end this session here. All the very best to all of you, and I think you guys did really well today. You knew answers to most of the questions, and I think you are very well prepared to give your exams and come out with flying colors. So I will write my email ID here. In case you have any issues, you can mail me here. I'll try to reply. You will get a PDF of this very soon, and we have all these videos, LLR videos, and we have mainstream videos, English videos in our PrepLadder app. So if you're still not a PrepLadder subscriber, please do that, because everything has been explained very well there. We've used a lot of new content and image overlays over there. So all the very best. Okay, so Dr. Sarthak, general questions in derma, okay, we'll take that. That would be pertaining to more of what you need in day-to-day life. I think that's important. Maybe we'll use that topic in one of these seminars. But if you have attended few of these seminars, we've talked about hair loss, we've talked about these questions also. No, this is the only derma session we have. We do not have derma session again. So most of this was image based only, though off and on we do keep image based questions, but in derma it's all about images. So even if you saw today, all these slides has only images, because in derma images is very important. So it was image based only. Right, so I'll wind up here, and all the very best to all of you. It was great connecting with you today. Thank you so much.